Good afternoon, everyone, and welcome to another survivorship webinar. This one is called Clinical Trials and Immunotherapy for Head and Neck Cancer. This is a joint initiative with the Head and Neck Cancer Alliance, the support for people with oral and head and neck cancer, SPOHNC, and Squeeze Biotechnologies. In today's webinar, we're going to hear from three distinct perspectives on clinical trials for head and neck cancer. We're going to hear from Jeff, who is the patient perspective. Jeff is a two-time survivor of head and neck cancer, and he has been in part of a clinical trial for head and neck cancer, and now helps patients to navigate the troubling waters of recent diagnosis and how to move forward. So thank you very much for joining us, Jeff. We are excited to hear your journey. Also, my fellow MD, Dr. Zandberg. Dr. Zandberg is an associate professor of medicine at University of Pittsburgh, and he's also a specialist of head and neck cancer. So Dr. Zandberg, thank you very much for being part of this webinar. And myself, I'm Ricardo Zwirtes. I'm the head of clinical development at Squeeze Biotechnologies, and until very recently, I was a head and neck cancer caregiver. So, but before we jump into the webinar and hear this perspective, I would invite you to hear from two of my favorite people in this world, Amanda Hollinger. Amanda is the executive director of the Head and Neck Cancer Alliance, and soon after her, we're going to hear from Marianne Caputo, who is the executive director at SPOHNC.
Thank you so much. Thank you for the warm introduction, Ricardo, and for the invitation to be here today. We're very excited, and we know how important clinical trials are for our patient population. I'm Amanda Hollinger, Executive Director of the Head and Neck Cancer Alliance, and our organization is a patient advocacy organization that has been in existence for over 20 years. We have a variety of programs, and I'll just touch very briefly on some of those. We have our Oral Head and Neck Cancer Awareness Week. Each year in April, we welcome anyone to join us with that. We have an online support community for patients. We have an ambassador program who are really our survivors and caregivers that are our boots on the ground in local communities. We have a peer-to-peer mentor program for both caregivers and patients to connect with others who've been through a similar journey. We provide a variety of educational webinars, including bi-monthly webinars on survivorship topics that culminate with a survivorship symposium each fall. And we also offer a clinical trial finder and a gas card program to help patients get to treatment. And I have a picture there on the screen of one of our ambassadors, Alyssa, who talks in her quote about the importance of hope. And through all our programs and educational efforts and our partnerships with organizations like Squeeze, we are really working to provide hope to patients. And so that's why we are here and what we do. And we welcome you to join us. So thank you. And I will pass it on to Marianne.
Thank you, Amanda. And my name is Marianne Caputo. I'm the Executive Director of SPOHNC. I've been here for almost 20 years. And our mission is strictly dedicated to raising awareness and meeting the needs of oral and head and neck cancer patients through our resources and publications. I'd like to thank Ricardo and Squeeze Biotech for inviting us to participate on this webinar, which is very important to the head and neck cancer community. And I'd like to thank Dr. Dan Zandberg and Jeffery Shoop, our champion of hope, who is a volunteer for SPOHNC, for participating as well and sharing his experiences and story here today. To give you a quick overall of our programs and resources, and also to tell you about our programs. Nancy Leopold, who was our founder here almost over 30 years ago, started the first support group. And today we have over 100 support groups throughout the country. These are a wonderful program for head and neck cancer patients. They are very involved in their support groups, and they provide encouragement and hope through this program and become like family. We also have in 2003 started a matching program where we match patients with survivors according to their diagnosis and treatment. And many, many patients have been calling us throughout the 30 years, and especially through COVID, and now even today because of all the mental instability that's going on within our environment today. We have many resources such as our books that have become very welcoming to our community, and also a very much resource which is called our product directory for side effects of treatment. We also have cookbooks that we provide recipes for patients and survivors throughout their journey who experience some swallowing challenges and are also on feeding tubes. We are on social media platforms such as Facebook, Instagram, and Twitter. And on our Facebook social media platform, we do have a private page blog just for patients, and there are over 1,000 patients involved in that blog. So if you're interested, please become a member of that blog, because all of you share your experience and volunteer some of the therapies and products that helped you in your journey. And of course, we have webinars, and we also engage our webinars with our support groups as well, where we share our experiences and resources and programs with our chapters, and provide educational materials as well as encouragement and hope. Next slide, please. So we also offer a clinical trial finder. So we find that many patients and survivors who are going through a recurrence are looking for clinical trials that might help them in their journey. And two of those organizations are called CareBox Health and Massive Bio. And you can find those two organizations on our website. And what these two organizations do is they have clinical trial navigators that take your diagnosis, interview you, and hopefully will match you with the appropriate clinical trial available according to your diagnosis and treatment. And of course, we offer educational information to increase awareness and decrease stigmas around clinical trials through our newsletter, which is given out and distributed every month throughout the year, and is featuring very topics of great interest to patients with head and neck cancer, and of course their caregivers as well. So thank you for this opportunity to speak today. Our motto, Together We Heal, continues Nancy's legacy of offering hope and encouragement. And thank you again for having us.
Thank you, Marianne. Thank you, Dr. Zwirtes, and everyone else in this panel for inviting me to be part of this webinar today. Hopefully my story will help others. My name is Jeff Shoop. In 2011, I was diagnosed with stage 4 HPV positive P16 squamous cell cancer. I was 56 at the time. And in keeping with the Halloween theme, I have a slide here that's very Halloweenish. It's a CT scan of my diagnosis. When I first noticed something going on, it was about a year before the diagnosis. I was always getting colds, and I started to have a problem breathing out of my right nostril. Well, if you look at that slide, that big white area is a swollen lymph gland, and then the big white area above it was the area in my nostril area. That's what was blocking it. So when I called the ENT and made an appointment, about a day or two before my appointment, my lymph gland in my neck swelled up to about half the size of a golf ball. And that's what that slide shows right there. So from there, they designed a treatment plan for me. Next slide, please. This is me before. I was a plump 220 pounds. And so the treatment plan was 35 days of treatment of radiation with 3 rounds of chemotherapy simultaneous. And it was cisplatin chemotherapy. So when they started it, the treatment, I had the chemo and the radiation start the same day. About 3 days later, I started having problems with my hearing. So luckily, the ENT that I first saw had a baseline hearing test done for me. And it proved out that when I went back again to see what's going on, it definitely affected my hearing, which is a problem because when I first was talking with the oncologist about it, I mentioned that I was a working musician and I wanted to maintain the hearing as much as possible. So when this happened, they kind of pushed back and said, you know, that only happens in a few people, so I wouldn't worry about it. But then I had to prove that it did. And once I did, we switched to another drug, Erbitux, and then continued on with the treatments. Next slide, please. This is a normal infusion day. It took about anywhere from 4 to 5 hours for the infusion. And then I would go to my radiation. So radiation was every day for 35 days. And the chemo was about every other week, something in that realm. And those weren't too bad. I mean, there was issues, but they weren't too bad. They were just long and enduring. And the radiation, you don't really feel what's going on for about 4 weeks or so. And then, you know, then you start feeling the pain and whatever that comes with the radiation. Luckily, the doctors also suggested I have a feeding tube. And the reason they did that is because they knew how much area was going to be affected in the radiation. So luckily I had that. And about the 4.5 weeks into it, I started needing that feeding tube to eat. So about the 5th week or so, it's got a little worse and a little worse. So next slide, please. This picture is about 6 weeks in. This wasn't the worst of it, but I'm sparing you all those pictures. But it was very painful. It was hard to swallow. I had a lot of swelling in my mouth, inside my mouth, so I could not eat, only could drink water. So the feeding tube for me was absolutely necessary. And so I got through that and went about another 3 or 4 months with the feeding tube. And then I decided I wanted to get off the feeding tube and just start eating some real food and going that route. And so next slide, please. So after about 7, 8 months, I lost 60 pounds. So I'm down to 160 pounds from the 220. And I stayed there for probably about 1.5 years at about 160 pounds. And I slowly gained weight back, which the doctors were really pleased that I was doing. And so also the plan is that once you get through treatment, you get a scan every year for the first couple years. And if you get to the 2nd year scan and it's clean, they usually say you're good to go and have a nice life. And unfortunately for me, at my 2nd year scan, they found tumors in my right lung. So they ordered a biopsy and found that it was the squamous cell cancer. So it was a a recurrence, but a metastasization of that cancer that migrated to my lung. So the doctor, my oncologist, said that I had enough radiation for a while, and he was suggesting that I look for another method. So he suggested a clinical trial. I didn't know anything about it. My wife and I never heard of these things. Kind of lucky for us, we asked a lot of questions during our first treatment. And I think because of that, my oncologist suggested that we search for a clinical trial. And he gave us the National Cancer Institute's website, NCI's website, to do the search. Now, this again was back in 2012. Luckily, as Marianne had suggested, there are better sites, newer sites, maybe not better, but newer sites that patients can go to today that might be a little more patient friendly. But the NCI website at that point was very much doctor oriented. So I had to put in, medical terms and all kinds of things figured out. But I came up with about 7 trials that I thought might be for me. So I gave them to my doctor. 2 days later, he calls me about 8:30 at night. And this little story goes sort of like Goldilocks and the Three Bears. So he said, no, this one's not for you. And this one's not quite right. It's just sort of, but not really. And these 2, maybe we'll talk about them later. So he said, no, this one right here, this one's for you. This is leading technology right now. It's immunotherapy. And it was for, the name now is called Keytruda. So that was the immunotherapy. And there were 2 variations of this clinical trial. It was a phase 2 clinical trial. So it's looking for the dose, the most efficient dose to use in this trial. So there was one at 100. I'm sorry if is it milligram or microgram, or I'm not sure, but one was at 100, the other one was at 200. So the 100 was 100 for every week, and the 200 was every 21 days. I happened to get the 200 at every 21 days. So the hospital that we went to, several hospitals that were offering this trial, but we ended up going to Johns Hopkins in Baltimore because it's a 2-year-long clinical trial, and we figured Baltimore in the winter it would be easier to get to. So that was our that was the criteria. Before I go on, I want to say the doctors, the nurses, the parking attendants, the vendors, all at that hospital were superb. I mean, you couldn't ask for a better group of people. They treated everyone very, very nicely. I went there a lot. So, but I never had, they just have a very good working scenario there. So at that trial, it was basically a half hour of infusion. And then, they did blood work to make sure you were okay. And you saw the doctor, and then you had your infusion. And on some days you would have a scan. It was a scan every 8 weeks. So I've had 27 CT scans. So I'm sort of glowing, sort of like that other thing. So I was one that particular trial. I believe I read there was 265 patients overall. I guess throughout the U.S. And I happened to be very fortunate in being one of the 5% that had 100% response to that particular drug at that time. So as of July of 2015, I've been cancer-free. And in about a week or 2, I go for my 6-year scan. So hopefully, fingers crossed, things will be good. And when I was diagnosed in 2014 with the recurrence, I didn't have any grandchildren. Next slide, please. And I'm here today because of that clinical trial. Now I have 2 children, grandchildren, and they're wonderful, make me laugh every day. And I was fortunate because I was not feeling well during the trial and all that. I was able to take care of my grandson for a year and a half. So I helped raise him those first year and a half. The other thing I want to mention about the trial versus the first therapy is that the immunotherapy for me was greatly less problematic than the original treatment of chemo and radiation. I did have fatigue. I did have some joint pain, but it was all very manageable. But I wanted to make sure I mentioned that. So the other thing was the quality of life. From radiation, I currently and forever will have dry mouth. My voice is gravelly, that will never change. My thyroid, I have to take medicine for that. My neck is stiff, that'll always be that way. And that's all from the radiation damage. The immunotherapy, I don't think I have any residuals from that. So I'm pretty much back to, I don't want to say 100%, but I'm in the 90% of being able to do things, and my quality of life is very good. I've adjusted to all these other little things that have happened to me as far as the dry mouth and all that. And because of that, I am able to keep doing what I didn't want to have removed from my life. Next slide, please. I still play music. I am a working drummer. I play probably, well, because of COVID, it's cut back, but this year I played 35 shows. I've done some session work. I'm currently working on a song for a podcast and for an art gallery, a traveling art gallery. So the way my family supported me through this, invaluable. Same thing with my SPOHNC group. Excuse me. Invaluable. The quality of life, the support I got from my family is wonderful. And the last thing is, I wouldn't be here today if it wasn't for the immunotherapy. I could have taken the standard protocol of a recurrence, but the more I look back at that, I don't think I would still be here today. And I was fortunate that I had 100% response with the immunotherapy. I think many people do see very good results from that. But I'm just so fortunate, and I feel blessed that I'm still here, and I'm able to give back, and hopefully my story helps others, and people that I volunteer to help. It helps them along and gets them through their treatment and their recovery. Thank you again, Dr. Zwirtes, and I guess now it goes on to Dr. Zandberg. Thank you.
So first off, thanks, Jeff, for that truly inspirational trial. One of my dreams is to play the drums in a band. So that's thrilling that is your profession. Thanks to everybody for giving me an opportunity to talk today. What I'm going to do is give an overview of head and neck cancer and where we are in the field, and where we need to go in the field of head and neck cancer. Next slide. So there are many different types of head and neck cancer. And when we talk about a head and neck cancer, we talk about something that starts within the lining of our throat and beyond. And you won't be able to see my pointer, but for our head and neck cancers, most of them start in the United States in the oral cavity. In the back of the throat, the area that we call the oropharynx, that has the tonsils in the back of the tongue, around the voice box, which is labeled as the larynx there, and then behind the voice box, which is the hypopharynx. And there's lots of different types of cancers that start in the head and neck, but by far our most common is squamous cell carcinoma, which comes in about 90% of cases. Next slide. So we have three main types of treatment for cancer, including head and neck cancer, and that's surgery, radiation, and drug therapy. When we talk about drug therapy, we talk about traditional chemotherapy, like the cisplatin that Jeff highlighted, immunotherapy, for example, nivolumab and pembrolizumab, and then we have targeted therapy, which is targeting a specific receptor, for example, that the cancer might be showing. How we use these therapies is based on the stage, and specifically whether we can use local therapies or not. For someone that has cancer, including head and neck cancer that's local, and by local I mean within the area that it started and also the lymph nodes in the neck, which is a very common area it goes to, we can use our local therapies like surgery and radiation itself. Very frequently, we also use chemotherapy with radiation, and that's to make the radiation work better. And then there are situations where the cancer can be beyond the use of local therapies like surgery and radiation, and that's where our drug therapy is used by itself to hit the body-wide. Next slide. You know, in head and neck cancer, there are two main categories of staging. One is local and locally advanced, and the other is recurrent metastatic, and that sort of sets the treatments that we use. Locally advanced, I mean someone that presents with a tumor that starts, let's say, in the back of the throat, and they may or may not have a lymph node in the neck. And locally advanced, we're talking about either a larger tumor on its own or multiple lymph nodes that are spread to the neck. The majority of the patients of our patients that present with squamous cell carcinoma of the head and neck present with locally advanced disease, and there we're using our therapeutics like surgery followed by radiation or chemoradiation, or sometimes just chemoradiation to try to get rid of all the tumor. And then there's the recurrent metastatic setting, meaning someone who has cancer that comes back and or spreads beyond the neck. Next slide. And nowadays, really, when it comes to patients that present, especially for locally advanced squamous cell carcinoma of the head and neck, we really have two different diseases. We have human papillomavirus positive, HPV positive oropharyngeal cancer. The oropharynx, again, is the back of the throat where the tonsils and the back of the tongue sits. And for these patients, we're looking at, can we keep the very good prognosis in the curative intent setting? And can we reduce the intensity of our therapy? And that reducing the intensity of our therapy can come by surgeries that are minimally invasive, followed by less therapy afterwards, or non-surgical therapy, for example, chemoradiation, where we're either reducing our radiation, trying a lighter version of chemo or no chemo. And there are various trials that are ongoing, some of which have already changed what we do in this pursuit. And then there are the remainder of our patients in the locally advanced setting, where we know that we need to continue to make things even better. And this is an area, for example, where we're adding immunotherapy to the treatment of patients with, for example, chemoradiation and otherwise, in order to improve things. And I'll talk about a little more about that at the end. Next slide. So recurrent or metastatic, that means you either have a local regional recurrence or distant metastatic spread, or both. And by local regional recurrence, that can be that it comes back at the site that it started, for example, coming back in the mouth again, or the cancer can come back just in the neck as a lymph node. And spread or distant metastatic spread means spread beyond the head and neck. The most common places head and neck cancer likes to go are the lung, liver, and bone. Next slide. So how we approach recurrent or metastatic head and neck cancer depends on where it is. We talked about our local therapies that we can use within the head and neck. If somebody has cancer that comes back within the head and neck, we reach for surgery. If no surgery option, then radiation. And if none of those, then drug therapy. And it's not as simple as a formula. The side effects of things and the therapeutic value of these modalities need to be weighed in every patient. And when we have cancer that's spread beyond the head and neck, there we're talking about primarily our drug therapy as our approach. Next slide. So, really a breakthrough that revolutionized the field 10 years ago and has also revolutionized head and neck cancer is immunotherapy. And from a basic perspective, immunotherapy means drugs that try to get the immune system to attack cancer. One class of these drugs are called immune checkpoint inhibitors. And if you think about the immune system like a car, there's two ways to make a car go faster. One is to press the gas pedal, and the other is to take the foot off the brake. The immune system has lots of gas pedals and lots of brakes. And so the breakthrough that made it to the press, starting 5-10 years ago, was these immune checkpoint inhibitors that specifically targeted something called PD-1 or PD-L1. So the tumor can express PD-L1 as shown as this slide. Our immune system, for example, our T cells, which attack cancer, they express something called PD-1. And PD-1 is a normal brake. It's there under normal circumstances, even if you don't have cancer, to slow down the immune system so it knows to stop. Because our immune systems has to work with absolute precision knowing when to attack and when to stop. Unfortunately, the cancer can take advantage of this PD-1 brake by using its PD-L1 and stepping on the brake of the immune system itself. And Erin, you can advance the slide a couple of times and some other things should come up. And one more time, thank you. So these drugs, for example, pembrolizumab or nivolumab, work by blocking PD-1, which is akin to taking the foot off the brake of the immune system so the tumor can't step on the brake, and then the immune cell can go and attack the tumor. Next slide. And these agents and agents like them have revolutionized the oncology field with approvals now as regular therapy, standard therapy in many, many different solid tumor types like lung, like esophageal, and also in some of our blood cancers. And this just shows you data from head and neck cancer with pembrolizumab. Now pembrolizumab is approved, FDA approved for use as our first therapy in the recurrent metastatic setting. And what this curve shows is that for those patients that had a response, that is their tumor shrunk when we gave the immunotherapy, it's showing you the duration of response, meaning how long did that response hold? And these two curves, the green curve is the immunotherapy, and the red curve is a chemo drug or chemo combination that it was compared to. And what it's showing you here, that top curve, you want it to be higher. It's showing you that the median duration of time that patients that responded to immunotherapy, that response lasted was nearly 2 years, 20 months. And seeing that was quite remarkable compared to our standard chemotherapy agents itself. And that is the promise of these type of immunotherapeutics. For those that respond, the potential for the duration of response can be long. And that's what's led to their approvals across the board. Now, as a field, we're saying, how can we get more people to get into this bucket of great benefiters? The response rate, for example, the percentage of people that do have that significant tumor shrinkage with pembrolizumab is only 20%. So the question is how can we get more people to benefit from pembrolizumab? And Jeff's story is inspiring and gives all of us hope that we can find a way to get more patients to benefit from immunotherapy, including long term. And so as a field, the next step in the recurrent metastatic setting, and I should highlight that this is recurrent metastatic squamous cell carcinoma in the head and neck, is how do we use combinations, whether that's with chemotherapy, with other immunotherapy agents, other targeted agents to get more people to benefit from immunotherapy. We've had some small gains since this data in 2019, but we've also had some combinations that haven't made headway, or they haven't shown what they need to do to make it to standard of care. And so still it's a great need as to how do we move forward. These drugs like pembrolizumab and others were a giant leap for the field. And essentially what we're doing through clinical trials in the recurrent metastatic setting is trying to find what is going to be the next great leap, the great leap forward. Next slide. One big interest for us, at UPMC Hillman is just that. How do we improve outcomes in the recurrent metastatic setting? How do we use different combinations with immunotherapy to improve outcomes? And that led us a couple of years ago to develop the recurrent metastatic head and neck cancer clinic, where our focus is on patients with recurrent or metastatic disease, whether those that need surgery or radiation again, or drug therapy. Next slide. And in part in doing that is developing clinical trials, unique clinical trials. These just show a couple. One looking at how can we improve or give more oxygen into the tumor, which can help immunotherapy. And the other is how can we make our therapy more personalized? How can we sample a patient's tumor, figure out what drugs might be needed from an immunotherapy perspective, again, to try to improve outcomes for patients. Next slide. So I think to summarize, in head and neck cancer, we have multiple directions in the field. Anti-PD-1 immunotherapy drugs have revolutionized the field in the recurrent metastatic setting. Now we need to make it better for patients that haven't seen immunotherapy before, make it better for patients that have already gotten immunotherapy and need better therapeutics. And with this gain has come, how do we use our immunotherapy in the upfront setting, that locally advanced setting, where we're using our surgery and our chemoradiation and things like that. There have been some efforts already with clinical trials adding drugs like pembrolizumab to chemoradiation, hoping that just adding it to chemoradiation would be better than our regular chemoradiation. And so far, it hasn't been as easy as we would have hoped, as a couple of those trials have been negative. So we're still searching for what is the best way to use immunotherapy in the upfront setting, where we're shooting to get rid of all of the tumor to make things better, whether that's giving it before surgery, whether that's using it afterwards. That's still something that we're searching for the field. So that gives you an overview of where we're at, an overview of the most common type of immunotherapy. And I will say that cancer care, I think, is the ultimate team sport. To get that pembrolizumab, right, which Jeff spoke about, that took away his cancer, right? That comes from immunologists, people that are studying the immune system, figuring out how immune cells work, what the tumor is doing. In this case, specifically that break PD-1 and its interaction with PD-L1. That takes clinical trials, first early clinical trials setting the dose, and then bigger clinical trials establishing the drugs how the drugs work. And those trials know that it takes a village, from people managing the data, people helping patients as they go through, our study coordinators, people behind the scenes that never get to meet patients that help with getting it through IRB, getting the study up and running, the contract work, all of that with the goal of helping our patients. From my end, it's really, I love the opportunity to speak, to speak at these type of webinars. For anybody that develops cancer, it's likely the greatest adversity that they've ever had to face in their life. And it's truly our honor as healthcare providers to fight with you every day. So thank you for this opportunity. And I'll turn it over to Ricardo for the next talk.
Thank you very much, Dr. Zandberg, and thank you very much, Jeff, for the inspiring talk. It's a pleasure to share this panel with two fighters like you both. What I'm going to talk here is about the sponsor or the industry perspective on clinical trials. So I will provide an overview of clinical trials and then dig a little deeper on oncology clinical trials and what we do here at Squeeze. So next slide, please. So why are clinical trials important? Clinical trials are part of the learning process, not only in oncology, but in medicine, right? And they do so by providing a structured framework for testing hypotheses that may affect the clinical practice and the care of patients, right? So the way it goes is it helps to separate all the noise. All patients are unique, all clinics are unique, doctors are unique, and the way that they treat patients, it may be very complex. So what clinical trials do, they try to identify this signal in the middle of all the noise, sometimes good noise, sometimes not so good noise, and with that advance the knowledge in clinical practice. There is some next slide. There are some myths regarding clinical trials. I pulled some of them here. One common myth in clinical trials is that people will be given placebo. I would like to make very clear that that's never the case when there is a standard of care established. So clinical trials, they undergo a very restrict approval process through ethics committees and make sure that patients will not, or the care of patients will not suffer, and they're only given a placebo when there's question if something should be given to patient, or there is absolutely nothing that can help that patient. Another myth is that clinical trials are only for patients in very, very, very late lines of therapy. As Dr. Zandberg alluded to, actually, everyone can be part of clinical trials. There is this research question if we should treat patients early on, especially with immunotherapy, if immunotherapy should be brought to earlier lines of treatment. So virtually everyone can be part of clinical trial. If the clinical trial, of course, is available in the institution that you are seeking treatment. Kind of corollary to that is that sometimes, despite the fact that you want to be part of a clinical trial, the institution may not have a clinical trial for you, or you may not qualify for a clinical trial. But it's important that you have this conversation with your treating physician and manifest your desire to be part or consider a clinical trial, because you may not qualify for a clinical trial now, but in the future that may fulfill that criteria. And another one is that once you are in a clinical trial, you have to remain in clinical trial forever. I would like to emphasize that the clinical trial participation is voluntary, so you will remain on clinical trial as long as it makes sense for you, and you can decline participation at any time. Of course, some studies will look for survival, and they would like to know what happened to you, but it's ultimately your decision on remain on the study or not. We have different types of clinical trials. We have prevention trials that, for instance, try to evaluate measures to prevent disease, like the recent COVID vaccine trials that we had a little ago, or the ones for HPV vaccine that showed that you reduce the incidence of HPV infection and therefore HPV-driven cancers. Screening trials that look at different modalities of screening and labs. Treatment trials, that is like the one that Jeff was part of. We're going to talk a little bit more about those. And quality of life trials. Sometimes these two are mixed together when you evaluate new interventions that may have a good impact in quality of life, which is the case of immunotherapy when you compare it to chemotherapy. You may also want to look into how that affects quality of life. And we heard from Jeff that it does have a significant impact on quality of life. The next slide, I think Dr. Zandberg, here talk about the phases of the clinical trials. So you hear that when you talk about a clinical trial, oh, there's a phase 1, there's a phase 2, there's a phase 3. So phase 1 studies are usually the first studies that are done with a molecule. They are to assess if a molecule or an intervention is safe. Phase 2 study is once it's established that it's safe to see if that works. So it's still collecting data for safety, but it's start looking more into efficacy and does it really work? Phase 3 are the big studies, the studies that compare then that intervention with the standard of care. It's likely the study that Jeff underwent, where you compare the immunotherapy to their standard of care. And then you have phase 4 studies that are studies once the drug is approved to see how is that being used in real world, where you start having a more heterogeneous population or population that was not necessarily included in a phase 3 trial. Here's this slide that I was mentioning that Dr. Zandberg already alluded to. There are different modalities in oncology. Surgery and radiotherapy are more are local interventions, while chemotherapy, target therapy, and immunotherapy are systemic. Immunotherapy in particular, which is one of the focus of this talk, covers checkpoint inhibitors, therapeutic vaccines, interleukins, CAR-Ts, oncolytic virus, among others. This it's the concept, the immunotherapy concept is something that has been around for a while, but as Dr. Zandberg mentioned in his talk, in the last 10 years or so, we have a strong advancement on this area with checkpoint inhibitors. Checkpoint inhibitors allow us to see what the immune system was capable of doing, and allow us also to learn. Going back to that concept that I mentioned in the beginning, these drugs help us to generate hypotheses and to really learn about the disease. If you go to the next slide, this is a slide that it's a little technical. Dr. Zandberg and I, we like this kind of slide, but it's really talking about the immunology and how your immune system or the steps that your immune system have to cover to get rid of cancer. We know that cancerous cells appear in your organism throughout every day, and your immune system is very vigilant in eliminating those cancer cells. And what happens is if this cycle gets stuck at any step, then you have cancer developing. And if you advance to the next slide, there is an animation. Yeah. And sometimes you need to give a push, and this push is with drugs, sometimes combining different drugs or different approaches such as radiotherapy, chemotherapy, or other immune therapies to make this cycle run again and get rid of the cancer. You have here step 7, anti-PD-1, that was the Keytruda, the drug that Jeff had the opportunity to use. So one of these important steps is vaccines. Vaccines have been around for a while. If you could advance the next. Yeah. Vaccines have been around for a while. And people have been testing the idea that if you give a little bit of the tumor, you can train your immune system to attack the tumor, right? So the next slide shows a comparison between the traditional approach of vaccines that are that enlist mostly CD4 T cells and antibody response. That are the vaccines that we have available, and those are great for you to have a prophylactic approach to be used for prevention, as the COVID and the HPV vaccines that we have available right now. And what Sweden is trying to do is to use a therapeutic vaccine. And our understanding is that you need a strong CD8 activation. CD8 are the cells that will attack your tumor. So you need a strong response. And in preclinical data, at least, we're able to show this very strong CD8 response. That's the plot that you see here in the far right. Next slide show how we do that. So we remove blood from a patient, and then we literally, as you can see here in step 2, we squeeze cells with a cargo that's allow the cargo to get into the cells, and then depending type of the cell and type of cargo that we put in, the cells will work either as antigen presenting or going to particular cells in your blood that will have this antigen presentation that will then work as with this vaccine mechanism. It's important to say that it's a very patient-friendly approach. No preconditioning. You don't need lengthy hospital stays. The vein-to-vein time is super short, and it's just a simple syringe push. This is still in phase 1. You guys are now graduating in clinical trials. So we're still looking into the safety and with a peek on the efficacy on this trial. And so far we have seen encouraging results. If you go to the next slide, it will show our pipeline. So we have 3 different approaches for this vaccines. 2 of them use white blood cells, 1 of them use red blood cells, all of them in head and neck, cervical, anal, meaning HPV-driven cancers, right? So we're super exciting. We are phase 1/2. As I mentioned, we are looking for safety, but also with an eye on efficacy. The next slide, I believe, is my last one, and is a reminder. You can click the next one. I think it has a build as an animation. Yeah, oh, fantastic. And it's for you to visit the Squeeze website. We have a page dedicated to patients, not only Squeeze, but if you want to learn more about your treatment or the trials that you may be considering. Most of the companies now, they have a patient page with very patient-friendly material, language that is not overwhelming, where you guys can learn and ultimately decide what is the best way to go. I would like to commend here the work that our advocacy groups do, Amanda and Marianne. I do believe that the best way to empower patients is through education, and that's fantastic work that our advocacy community is doing. Thank you very much. Great. I would like now to open for questions. I think there is a couple questions here in the queue. So, and we also have some very nice comments. Jeff, we have a person here saying that he or she is a 3-time cancer survivor, has an HPV cancer, had recurrence in the lung, and then ended up having a spinal cell cancer in the base of the tongue. So far is still surviving. It's very happy to see you share your story, and it's saying that it's very inspiring to hear from you.
Well, keep on persevering. You got to keep pushing, keep asking questions, and develop your support group. Your family or friends or whoever, your support system, to help you get through it. Mm-hmm.
Fantastic. So I guess the first question that we have here is, what percentages of patients have metastatic and recurrence head and neck cancer compared to local or locally advanced disease? I guess at first presentation, Dr. Zandberg, what proportion has advanced versus local disease?
Yeah, great question. So with squamous cell carcinoma in the head and neck, only 10%, excuse me, present with distant disease. So only 10% when they're diagnosed has cancer that's spread already outside of the head and neck region. So 90% present where it's just within the head and neck. And the majority of patients present at what we conceptually think of as locally advanced stage.
Fantastic. Thank you very much for the folks who are sending us messages. We have many cancer survivors here on the call, including Robert, Ron, Gary. They all wish Jeff congrats on being cancer-free, and very inspiring story. Thank you very much, Jeff, once again. Yeah, I guess one question is from a clinical trial perspective, Dr. Zandberg, any thoughts on how can sponsors make clinical trials more easy on patients or more attractive? What can we do better to ensure that patients are being considered for clinical trials? I guess that question goes for both Jeff and Dr. Zandberg.
Yeah, no, go ahead, Jeff.
Well, I found out about my clinical trial through my oncologist, but I think a lot of people are kind of hesitant, maybe because they feel, you mentioned it in one of the slides about placebo or not, and I think there's some misconceptions that are, or preconceived definitions of things that are a little off base. Almost everyone I've talked to that asked me about a clinical trial, the concept of the randomized and placebo is very confusing. And so I help try to clarify that. And the other is I drove from my home to Johns Hopkins, which is an hour-and-a-half drive each way. I did that every 21 days. I've had people tell me they would never do that. And I scratch my head over that, but that's me. I was willing to do whatever and travel however far. I've met other people in the trial that I was in. A gentleman was from South Carolina, and he flew to Baltimore every 21 days. Another gentleman was from New Mexico, and he flew to Johns Hopkins because that's where the trial was. There weren't any out west. So there might be an issue with locale, either not everyone has the trial, or they may not have the machinery for the trial or whatever. But I think for patients, it's a little, I think it just has to be discussed and the definitions need to be clarified. And then I think more and more people might reach out. And maybe talking to other groups, other communities, other groups, just other than or reach out through webinars like this to these different communities and where there might be higher risk, that kind of a thing. This particular, like mine, HPV, that's everywhere. I mean, it's not an environmental thing, I don't think. It's kind of widespread. So.
Yeah, thanks, Jeff. I think that's really well said. And I think from a physician perspective, as Jeff highlights, one is access, right? A lot of these trials sit at university settings, academic centers, which aren't easily accessible for everybody, which are not easily accessible for everybody, right? And I think that, many cancer centers, including our own, are developing a model where we have affiliates that are out in the community that can also open and run clinical trials. Not all clinical trials, can be done at community or network sites. But that gives greater access when you have trials in the community that patients live, right? Which cuts down on travel and cost and everything like that. So I think that is a general trend in cancer care, which hopefully will also lead to more patients being able to benefit from clinical trials. And then just as Jeff highlights, I think rightfully so, right? People thinking about randomization, people thinking about, the experimental nature of things is daunting, is definitely daunting. And, as a provider, right, the goal is to educate. And the goal also is to talk about the pros and cons, right? And then also help with a recommendation, right? Because sometimes it can be very daunting, right, for a patient to think on their own, should I do this clinical trial or not, right? Which is part of the counseling. But, to your point, Dr. Zwirtes, as a field, right, it's only a small percentage, very small percentage. I don't know the exact number, but I think it's around 10% of our cancer patients in general, right, that get on a clinical trial, right, for the multitude of challenges, that abound, and is something that, we as a field need to do a better job of.
Absolutely, absolutely. We are already ahead of time. I just would like to thank you everyone again for the attendance. Before we go, from Dr. Zandberg and then from Jeff, what's your advice for someone who's starting their journey on head and neck cancer right now?
Well, I found several things through my experience. One, be proactive in your own treatment. Ask a lot of questions, do a lot of reading, and make sure it's reputable sources, but do a lot of reading. And make sure you tell your nurses as you're going through treatment, tell your nurses how you're feeling, because they'll relay that to the doctor, or they'll already know how to help you out. My radiation nurses were, wow, they were very helpful to me. And the other end is go in with a positive attitude. I decided about halfway through my radiation days, and then all through my recurrence, is when I went for treatment, I accepted the treatment. I accepted what was going to happen. So my body wasn't fighting it mentally or physically, fighting the treatment. I let it happen to me. I think that was a big, big, big factor in me getting through this. And the last thing is, and the doctors don't necessarily talk about this, but it's very important, I think, is nutrition. Stay up on your nutrition, especially if you're getting radiation, stay hydrated. You do not want to become dehydrated. Stay very hydrated, and you eat well during this. And your body's going through a lot of things. You gotta give it the fuel to fight it. So those are the few little. I'm sure I could think of more, but off the top of my head, that's the ones.
That's great.
Yeah, I think that's well said, Jeff. And I can't, there's questions in the chat that I can't answer fast enough, but just to address a couple of them that came up, which I think are good ones to highlight. Some people on the chat have asked about long-term symptoms and what's out there. And the truth is that is an area of great need, right? Which, there is less going on, unfortunately, right? Because our patients that don't have any cancer left are left with long-term side effects, and that's a great need. Some academic centers or otherwise have survivorship clinics. We have one here at UPMC Hillman, for example, that focuses on late symptoms of head and neck cancer. So for those that pose those questions, that may be a good start to get into those clinics. Most of those clinics have swallow therapists, physical therapists, occupational therapists, dentists, right, all attached to them to handle some of those those longer-term side effects. And then someone posed a question about what about HPV negative? So the data that I showed, that curve that I showed about pembrolizumab and its approval is also for HPV negative. So that immunotherapy standard of care is for HPV negative and HPV positive. And actually, you know, the effects of the immunotherapy are fairly similar between HPV negative and HPV positive, at least with pembrolizumab. The story there is a little bit longer, which I won't bore the crowd with, but generally speaking, the percent that responds is pretty similar. And then I think Jeff, you know, said it best when he talked about some of those important things upon embarking on therapy itself. And I think that, you know, it is trying to garner as much support as you have, reaching out to your loved ones, reaching out to your friends, right? To form a support team if possible, right? To help you through the process. You know, I think that's definitely key, you know, as I treat, you know, with all the patients I treat and having that support. And I think that, you know, I've heard patients tell me this, you know, repetitively, you know, the treatment, for example, the chemoradiation that we do a lot, right? During the treatment, there's a lot going on. The adrenaline is rushing, right? Mentally, the patient is prepared as much as anyone can be for it. And it's very difficult treatment, as Jeff highlighted. And then there's this drop off. There's this drop off after all that ends, right? The symptoms do not go away. It takes a while for those symptoms to fade, right? And it ends up being, you know, a big psychological and physical challenge after it's done, right? And, you know, because the symptoms are still there, it takes time for those to go away and improve the pain, other things. And that's, you know, when a lot of patients, I think, need the most support or even more support is during that juncture. So I think that's something that we try to prepare our patients for, is that journey of our, you know, what is our more common therapy, surgery, chemoradiation, radiation alone, which is the intense phase, right? And then the recovery phase and its challenge itself.
Very true.
Fantastic. Well, thank you very much, Dr. Zandberg. Thank you very much, Jeff. It's always a pleasure to hear your story. I heard that more than once, and every time is very inspiring. Thank you for all the attendees, and thank you, Amanda and Marianne, for the partnership in doing this webinar. Thank you very much. Thank you all.